I need to work with local docs. Where do I start? Diagnosed with dysautonomia, EDS, histamine, not sure what that means, vestibular migraines, oscillating vision, small fiber neuropathy, no real cause or treatment plan. Well, okay, so I'm gonna give you this in a way that is not meant to be harsh, but it's gonna be like objective. So when we look at it, we've got like a dysautonomia diagnosis. Okay, cool. We've got this component of just a very simple structural component with the EDS. Histamine, I'm assuming that's some sort of like mast cell type thing. It'd be nice to know if we've measured that or if we're assuming that. I've noticed lately that sometimes that just gets like EDS and MCAS like get thrown into the mix without testing for it. They just say, well, you probably have these things too. So it's worth knowing if we're testing for them or not. Vestibular migraines, oscillating vision. So vestibular migraines are typically like the come and go versions of dizziness that come in spells, like a migraine would come in a spell. They tend to be relieved with sleep, and they're not described. It's dizziness not described by BPPV in the periphery, nor swelling or inflammation within the vestibular or the vestibulocochlear nerves or central origin. So sometimes we can miss a thing or two with a vestibular migraine. It's not a true migraine, but we can't know without looking. The oscillation in the vision, I'm not sure if that's like describing square wave oscillations or if it's oscillopsia, where I perceive, like when I move, the world is bouncing. That would be oscillopsia. And then small fiber neuropathy is separate. So that's obviously going to be in the peripheral nerves in the legs or the arms or the trunk or whatever it is. Okay. So you got a lot of different smattering of things. If you're looking for a local person, I have to recognize that we have these correlated problems. These things all tend to go together, but they're in different systems. So when you look for someone local, you have to look for someone that is going to understand how these things are all correlated. You also have to determine what type of treatment protocol you're interested in. Are you interested in something where we're looking for a medication to resolve some of the symptoms, to get a little relief, feel a little bit better? Are we looking to solve the underlying? What are we looking for? And then you're going to back out to like what, in my geography, how far am I willing to go? What is the talent pool like in that area? And what is the likelihood that that talent pool is going to be able to solve my problem? Now, with doctors, it's hard because sometimes we forget. It's the same as anything else where you should interview. Like right, the same way you might say, like, I want a good attorney or I want a good accountant. Like, and you interview them and you see if it's a good fit. Sometimes we just go to the one we get and they're not a good fit and we get stuck with them. So it's important to remember that you're kind of interviewing your doctor too. You're trying to see if you feel like based on the things that you understand, can they add to that? Can they do things for you that'll help you to be able to move farther down the road? So I'm not giving you a specific answer of here's where you go look. There's some resources at the ACNB, although I think their website's not, I think it got hacked. I don't know if that's fixed yet. But unfortunately, I don't have a good answer because it's going to be like you're going to have to hunt around in your area and do a little bit of research, which that is a question I am super sensitive to because, I mean, as you guys know, I mean, there are people on here from all over the world. There are people in clinic from all over the world. It is not easy to find somebody that feels like they got a grip on these things. So I'm sensitive to that. I know that's tough to find. Like the candid part of me wants to say like, come to Michigan. But I know that is not for everyone. So I don't want to say that. I don't want anybody to feel bad. And then the second way is to go like, how do we find somebody near you? But that's the honest answer is like, we actually have to think about it in terms, we got to like start with what the end result is that we want and then work our way back. Say like, well, I'm looking for someone that's maybe not going to try to mask it with medicine, which means you need someone that's focused on that medicine. Or you might need to say like, I need them to be able to understand the autonomic part, but then I want them to be able to weigh in on how all these things like work together. So finding people like that is really useful. I have some colleagues that are learning that and that are sharp and really great people. Sometimes there's cardiologists that are wonderful, neurologists that are wonderful. I just don't know. We don't have like a WhatsApp chat to talk about that. So I apologize for that. My docs at the Veterans Affairs clinics are against a visit to your clinic I'll see you in October. Can you explain the cultural divide between functional neurology and the hospital setting neurology? In a traditional neurology setting, I can't speak for all neurologists, but when I try to put myself in their shoes, I think about, okay, where did I train? I'm training at a big school. How did I get in the neurology program? I'm super smart. And people tell me I'm smart. So I believe that. And then I'm going to go do a residency. Where am I going to do a residency? In the hospital. So the people that you see are going to be largely hospital-based, clinical-based people. And we're mostly worried about things like stroke, brain tumors, neurodegeneration, seizures, maybe a little bit headaches, right? But a lot of things you're really going to be passionate about are like not dying. And most things are going to be driven by like pure pathology, like we're looking for something real bad. We're going to try to keep you alive. And the tools available are going to be, I can write you a prescription for medication, or I can send you for a surgical consult, or I can send you for another consult within our allied fields, or I can send you for like PT or OT. But I don't do those things. So like if I'm a classically trained medical neurologist, I'm not also trained in PM&R. Like I'm not trained in physical medicine and rehab or PT. So you're just kind of counting on like passing that off to other people or passing off some testing or to the surgeon. So you're triaging a lot. So it's just a different thought or a different approach. With functional neurology, you're looking at a different type of pathology. You're looking for like, what is less than optimal here? I'm trying to solve the problem of, can I help you function better in your life day to day? Like that, it's a different problem set. You're trying to solve a different thing. And because of that, you're going to think about like, well, how do I make this work a little better? And typically the functional neurologist is the person that's also kind of tied to the therapeutic rehab. So they're also kind of like tied into what we're going to do. And that's helpful because most functional neurologists, the pattern is you're going to look at a thing, you're going to observe it, measure it, you're going to provide a therapeutic outcome, and then you're going to see if it changes. And then you're just doing that replicable change over and over again, trying to walk people up the ladder of function. So there's just like it's structured a little bit differently because you're part of it and you're seeing the whole loop, and you're doing that assessment over and over again in the moment. You're not like kind of sending it off and maybe I'll hear back from you in 6 months. You're like, it's dynamic in the moment. And that's the part to me that's really exciting, because it's like you're playing the game. You're like, I'm trying to solve this problem and I'm going to do things and I get feedback on how I'm doing, and we're just going to keep rocking and rolling like that until we walk that system up and make it stronger. It's like the personal trainer coaching me that gets to like see that outcome. And the thing that's awesome about the brain is that it happens fast. It's not, the delay of neuroplasticity is relatively quickly, so you can see things moving and changing on a pretty rapid basis. So I would say that is like the functional difference. And then also like most functional neurologists are chiropractors, and again, I can't jump inside anybody else's head, but there's been a long time stigma that it's like they're not as good, and that's fine. I don't really care. But whether it's true or not, like people just say that, or they have their own biases or their own critiques, and they'll express them. I don't think it's that, helpful sometimes, but it's just the way people are. And whatever, we try to win by putting good ideas into the marketplace and seeing what comes out, putting good results into the world, seeing what comes out, and then eventually those things become undeniable because they happen and we're recording them. And then we can show like, oh, maybe it's worth thinking about these things. And I don't think most neurologists are that way. I have great relationships with a lot of medical physicians that are really open-minded. We just had a med student on today. So I don't think that's everyone. And I think actually our newer doctors that are in the ranks are really open-minded and are getting curriculums that are helping them see those things, and they're open to it. And I think that's a really good sign. I don't think our payment structures are kind of built for that yet, but hopefully that will continue to come. But that's my take on it. But I really hope that maybe through success, people become more open-minded to that, and then you can serve as somebody that gets to help a lot more people, which would be pretty cool. So I would love that.